off.
Thanks very much, Dana.
Yeah.
Good morning, everyone. Thank you so much for being here with us today to talk about Medicare in 2025. Jessica and I are very happy to be with you today. As Dana said, my name is Katy McKee. I use she, her pronouns. I'm a white woman in my 40s with short blonde hair, wearing a gray sweater and a blue scarf. And I am a supervising attorney in the Pittsburgh office of the Pennsylvania Health Law Project. I will let Jess introduce herself.
Hi, everybody. My name's Jessica Lippert. I am also a female in my mid-40s. I have short brown hair. I'm wearing glasses today, and I have a turquoise sweater on. And I also use the she, her pronouns. And I work with Katy, technically out of the Pittsburgh office, but I am in the middle of the state.
All right, thanks, Jess. So as Dana mentioned, we'd like to encourage you to chat in questions as we go. There is a Q&A box. You can also use the chat function. We are going to stop several times throughout the presentation to address some of your questions because I know we're going to be going through a lot of material today. All right, so let's get started. Next slide, Jess.
Well, let's do our poll question first, if that's
Oh, yeah,
okay. Yes.
absolutely.
Let me bring that up here. All right, so hopefully everybody can see our poll on the question. You can, oh, everybody's jumping in. Feel free to put in your level of Medicare knowledge. We'll give it a couple of seconds here. You guys are on it. Just a few more seconds and I'll stop that poll. And I'm going to share our results. So it looks like the majority of you are in that intermediate level. We have a lot of beginners and a few experts. And again, a few that say, I don't know, which is okay as well. I hope you do learn a lot today. So let me stop sharing that poll and then I will hand it back over to you. And hopefully the slide will move there. There we go.
Thank you. All right. So just for folks who may not be as familiar with us as others, we are from the Pennsylvania Health Law Project. We are a Pennsylvania statewide legal aid program. We provide free legal services to help people having issues with Medicaid primarily, for people accessing Medicaid coverage and Medicaid covered services. Although our primary focus is Medicaid, we work with a lot of low-income Medicare beneficiaries who are dual eligible for both Medicare and Medicaid. So that is an area that we focus on also. Our services are free. Anyone can call our office. People can reach us through our helpline, which is open most Mondays and Wednesdays starting at 8 o'clock. We have tons of consumer education material on our website and our resource library. We also have a monthly newsletter. We encourage folks to sign up if you're not receiving our newsletter. We provide updates about issues with Medicaid and Medicare. And then we also do trainings like this one and systemic advocacy to improve the Medicaid program, primarily by advocating with the state. All right, next slide. All right, we are going to go through just a quick review of Medicare basics before we get into Medicare updates today, just to make sure we are all on the same page. I know we have a diverse group of folks here with different levels of Medicare knowledge. So for some of you, I know this will be a review, and for others, hopefully this is some helpful information. Then we'll go through Medicare updates for 2025. And finally, we will talk about programs that help with Medicare costs. As I mentioned, our focus at the Health Law Project is really on low-income Medicare beneficiaries, so we want to get into those programs that can help folks with their Medicare costs, since we know Medicare is good coverage, but it can also be very expensive. All right, so let's get into Medicare basics. Next slide, please. All right, so Medicare is a huge program. Medicare is a federal health insurance program, as you can see on the slide. We just wanted to give you a sense of the scope of the Medicare program. Enrollment data from July of this year tell us that 67.7 million people across the United States are covered by Medicare. That's 19% of the US population. And 2.9 million people are covered by Medicare in Pennsylvania. The Social Security Administration handles the eligibility end of Medicare, what handles enrollment in Medicare Parts A and B, and is also the agency through which people can apply for extra help with their prescription drug costs, which is one of the programs we're going to talk about later in this presentation. The Centers for Medicare and Medicaid Services, also called CMS, oversees and administers the Medicare program, handles enrollment into Medicare Advantage and Part D prescription drug plans, and also oversees the Extra Help with Prescription Drug Cost program. Okay. So Medicare comes in parts. When you become eligible for Medicare, you get a red, white, and blue Medicare card. That's what you saw on the first Medicare Basics slide. That red, white, and blue Medicare card provides your Medicare Part A and B coverage. Medicare Part A is also called hospital insurance, and it generally covers the care that people get in a facility or that people need following inpatient care. So it provides coverage for hospital stays, short term, up to 100 days of care in a skilled nursing or rehab facility, and then home health after a qualifying hospital stay and hospice care. Part B is your outpatient coverage. So this covers most of the care that people get on a regular basis. So just your regular doctor's visits, outpatient procedures, tests, all that kind of stuff that people are generally going to the doctor for. That is covered by Medicare Part B. Medicare Part C is just a different way to get that A and B and usually Part D coverage also. So it's just a different system for receiving that coverage through a private insurance company. So if you use your red, white, and blue Medicare card, we say you're enrolled in Original Medicare. If you choose to enroll in a Medicare Advantage plan to receive your Medicare Parts A, B, and C, or A, B, and D, you're just getting that coverage through a private insurance company, through a managed care company. Some people are more comfortable with that because that's what they're used to. Often employer coverage and a lot of Medicaid coverage is through managed care plans, so people are used to that. Medicare Advantage is required to cover all Part A and B services. Often people like it because it also covers some extra benefits. For example, dental, vision, sometimes gym memberships, over-the-counter catalogs. If you're enrolled in a Medicare Advantage plan, you must follow the plan rules. You're subject to a plan network. You have to go to in-network providers, get referrals, prior authorization. So there's a lot more rules that you have to follow if you're enrolled in a Medicare Advantage plan. Okay, so we talked about that's not a separate benefit, just a different delivery system. And then Medicare Part D is Medicare's prescription drug coverage. If you have original Medicare, you need to enroll in a separate Part D plan for your prescription drug coverage. If you're enrolled in a Medicare Advantage plan, most Medicare Advantage plans include prescription drug coverage, but you need to check to make sure. All right. So let's get into the next slide. So who gets Medicare? People become eligible for Medicare when they turn 65, or if they've been receiving Social Security disability benefits for 2 years. And finally, there's a smaller category of people if you have end-stage renal disease and are receiving dialysis or have had a kidney transplant, you can be enrolled in ESRD Medicare. How does someone enroll? If someone is known to Medicare and already, or known to Social Security and already receiving some kind of Social Security benefits when they turn 65, they're automatically enrolled. Otherwise, you need to make yourself known to Social Security and enroll. If you are already known to the Social Security Administration, you get a Welcome to Medicare packet and the red, white, and blue Medicare card in the mail. Um, but we know that more and more people are not receiving Social Security benefits at 65 because the full retirement age keeps going up and people are waiting to start collecting their Social Security retirement benefits. So if you're in that boat, you have to take action and contact the Social Security Administration to enroll in Medicare. If people aren't sure whether they need to act to get Medicare at 65, they can reach out to Social Security or Medicare, or they can contact the PA Medi program here in Pennsylvania, which is Pennsylvania's state health insurance program, assistance program that provides free assistance to people on Medicare with enrollment issues. So enrollment periods do apply to Medicare. You can't just enroll at any time. For those of us who are more familiar with Medicaid, you know that with Medicaid, you can enroll at any time. Medicare does not work that way. There are specific enrollment periods that apply. And if you wait to enroll, you may have a gap in coverage or may be hit with late enrollment penalties. So it's important to be careful about enrolling, usually when you're first eligible. And we linked on the last slide to the enrollment rules for parts A and B, for parts C and D, and then special rules for ESRD. So if you need more resources about this, please feel free to, we have lots of links throughout the materials in this presentation. Click on those for more information. So just to start with Medicare Part A and B enrollment periods, when you first become eligible for Medicare, you get an initial enrollment period, which is the 7-month window surrounding the month of your entitlement to Medicare. So if I turned 65 today on November 13th, um, I would have become Medicare eligible starting November 1st, and I would have gotten my Welcome to Medicare packet and been able to start the enrollment process into Medicare 3 months prior to November, and then 3 months after this month. You get the 7-month window to enroll in Medicare Parts A and B. If you miss that initial enrollment period, there is also a general enrollment period that occurs every year from January through March. And then the coverage starts the first of the month after the month you enroll. If you sign up for Medicare Part A and B during the general enrollment period, you also get a special enrollment period to sign up for Part D. And we have just a note here that if you miss your initial enrollment period and have to enroll during the general enrollment period, you may have a late enrollment penalty. There are also lots of special enrollment periods. So for people who maybe have employer-based coverage due to their own active employment or the active employment of their spouse, they can choose to wait to enroll in Medicare Part B. And then if they lose their employer-based coverage, they get a special enrollment period to enroll in Medicare. Also, loss of Medicaid is a basis. Sometimes this happened a lot during the public health emergency. People were on Medicaid. They became Medicare eligible and maybe decided, I don't want to have to pay for Medicare Part B. I'm going to just stick with Medicaid, and then later lost it. They would have a special enrollment period to enroll in Medicare Part B without a late enrollment penalty. There are other Part A and B special enrollment periods. For example, if somebody was incarcerated and missed their Medicare enrollment period, they also have a special enrollment period to enroll without a late enrollment penalty. And of course, there's lots of nuances with Medicare. So if you need more information, click on the link to get more information about Medicare Part A and B special enrollment periods. There are also enrollment periods for Medicare Parts C and D for Medicare Health and Drug Plan enrollment. Of course, you can choose to enroll in a Medicare Advantage plan or Original Medicare with a Part D plan during your initial enrollment period. Right now, we're in the annual fall open enrollment period, which lasts through December 7th. This is an opportunity for anyone with Medicare during this time can review their Medicare coverage. We encourage everyone with Medicare during the fall annual open enrollment period to review their Medicare coverage and make enrollment changes if their plan is no longer appropriate for them. So people can switch from original Medicare to Medicare Advantage. They can change their Medicare Advantage plan, change their Part D plan, make whatever enrollment choices they need to, and then those changes take effect January 1st. There is also a Medicare Advantage open enrollment period, which takes place every year from January through March. This is for people who are enrolled in Medicare Advantage plans as of January 1st. Sometimes people enroll in a Medicare Advantage plan. The new year starts, the plan takes effect, and they realized, oh, shoot, this plan doesn't actually cover my doctor, or it doesn't cover a medication, or maybe they had a change in their circumstances. During that period of January through March, people in Medicare Advantage plans can change their Medicare Advantage plan, switch to a different one, or they can choose to go back to original Medicare and a prescription drug plan. There are also lots of special enrollment periods for Medicare Part C and D, related to if you move, if you lose other drug coverage, if you lose your Medicaid or become Medicaid eligible, you get special enrollment periods to change your coverage. People who are enrolled in PACE and PACENet, which is a program that helps with prescription drug costs that we're going to talk about later in the presentation, get a special enrollment period once a year. There are several different special enrollment periods that people can take advantage of. So I think this is a nice chart to just understand the different ways that people can choose to get their Medicare. If people decide to stick with original Medicare for their Medicare coverage, they have that red, white, and blue Medicare card. They can add prescription drug coverage, can and should really add prescription drug coverage. And they can also add supplemental coverage. That could be a Medicare supplement policy, a Medigap, or it could be Medicaid. A lot of the people we work with have both Medicare and Medicaid as their secondary coverage. People can also choose to get their coverage through a Medicare Advantage plan, which includes their Medicare Part A and B coverage. Most of those plans include Part D coverage, and then often they include some extra benefits that we talked about. One thing that we haven't talked about is costs, and I know Jessica's going to go through Medicare costs, but the reason that many people in original Medicare need supplemental coverage, either through a Medigap or through Medicaid, is because with original Medicare, Medicare covers 80% of your hospital and outpatient costs, and then you're responsible for 20%. So that's not so bad if you have a doctor's visit that costs $100, Medicare pays 80, you pay $20. But if you have an outpatient procedure that costs $10,000, Medicare would cover 8,000 of that, and you'd be stuck covering 2,000 of that if you don't have any supplemental coverage. That's a very basic made up example, but just to kind of illustrate the way Medicare coverage works and that 20% co-insurance works. So for people with original Medicare, in order to control costs, they really do need some kind of supplemental coverage generally. We know that Medicare Advantage enrollment has become more popular over the last several years. It's now above 50%. Of people with Medicare are enrolled in Medicare Advantage plans. As of March of this year, 57% of Pennsylvania Medicare beneficiaries were enrolled in a Medicare Advantage plan. And that is higher. You can see from we just thought this was kind of interesting, but you can see from the graph that Southwest Pennsylvania has a very high concentration of people enrolled in Medicare Advantage plans. And then Northeast Pennsylvania, there's more people enrolled in traditional Medicare, original Medicare. So there's lots of considerations for people when they're deciding, how do I want to get my Medicare coverage? And we've talked about some of those, but costs, with, like we talked about with original Medicare, you're responsible for 20% coinsurance. You need some kind of supplemental coverage if you can't afford to just pay that out of pocket. On the other hand, if you're enrolled in a Medicare Advantage plan, you're limited to the plan's network, to the doctors that are in the plan. You may need referrals. When you're looking at your Part D prescription drug coverage, the drug plans all have different formularies, different drugs that they cover. So you need to look at that carefully. A lot of people are really enticed by the extra benefits that are offered by Medicare Advantage plans. And it's important to understand, what those extra benefits actually entail, what you're actually eligible to receive, and also to try not to let that sway your enrollment decision and making sure, are my drugs covered? Are my doctors covered? Um, am I going to need to travel to get care? If I travel a lot, maybe original Medicare would be better for me because I could see a doctor anywhere in the country, versus someone who is mostly in one area and is okay with being limited to a provider network. For people who get their Medicare coverage through their employer, like a retirement plan, they might not have a choice. And so you're kind of stuck with whatever coverage your employer provides for retirees. We didn't talk about this earlier, but there are, for people who are dual eligible for both Medicare and Medicaid, they can choose a special kind of Medicare Advantage plan called a dual special needs plan. This is just another kind of Medicare Advantage plan that is limited in its enrollment to people who are dual eligible for both Medicare and Medicaid. Some of these plans allow people who are partial duals who just get help with their Part B premium, maybe from Medicaid, to enroll. But people who are dual eligible are not required to enroll in those plans. They have the same choices as everyone else. Those dual special needs plans, I know are often a really attractive option, but they're just another option. And they're not always the best option, especially if somebody is a partial dual. Okay, so just briefly, we wanted to talk about Medigaps. Medigaps are also called Medicare Supplement Insurance Policies. These are sold by private insurance companies. There are hundreds of options from a variety of insurers, and they only work with original Medicare. What they do is fill in the gaps of Medicare. So we talked about the 80/20 coverage that original Medicare provides. So the Medigap fills in the gap by paying for that cost sharing. You have to have both Medicare Part A and B, pay a monthly premium to enroll in a Medigap. Medigaps do not cover any extra benefits. They're just filling in the gap of original Medicare coverage. The best time to join a Medigap is when you first get Medicare. Otherwise, you can be refused coverage or you can be charged more based on your health conditions. And the plans are standardized. So the plans all have the same, that have the same letter, have the same coverage, but the costs may vary. We don't work with a lot of folks, this is not a big area for us because we're primarily working with low-income Medicare beneficiaries who may be eligible for Medicaid. And if you have Medicaid, you don't really need a Medigap, but we wanted to provide some information about this, and there's a link to a guide to choosing a Medigap policy. So there are rules around when people can get a Medigap policy. There is the Medigap open enrollment period, and that is the first 6 months after someone is enrolled in Medicare Part B. Um, if someone in Pennsylvania, we allow people under 65 also to enroll in Medigaps. You get another chance at an open enrollment period when you turn 65. If you became Medicare eligible before 65. People on full Medicaid are not supposed to be sold Medigap policies. Medigap companies should not be selling Medigap policies to people who have Medicaid because it's duplicative coverage. There are also some guaranteed issue rights. So there are other times, other circumstances where someone might become eligible to enroll in a Medigap. The reason that this is important when you choose to enroll in a Medigap, either when you first become eligible or when you have a guaranteed issue right, is because at those times, the Medigap company has to sell you a policy and they can't charge you more because of your health issues. If you try to enroll in a Medigap outside of that open enrollment period or outside of when you have a guaranteed issue right, um, the company does not have to sell you a policy, or they can charge you more because of your health conditions or make you wait for coverage to start. So if somebody is thinking about their Medicare coverage choices and they're in their initial enrollment period, that really is the right time for them to enroll in a Medigap. Sometimes we talk to people who are enrolled in Original Medicare, they have a Medigap, and then they become eligible for Medicaid. There is a special rule that people who become eligible for Medicaid and have a Medigap plan can suspend that plan by contacting the Medigap company for up to 24 months. And there's some guidance about that, but you have to request suspension within 90 days of being approved for Medicaid. So that kind of allows people some grace time to figure out, okay, now I have Medicaid. This would be a lot cheaper for me if I don't have to pay that Medigap policy. Let me see if this works. Or if somebody's worried they're going to lose their Medicaid and don't want to just give up that Medigap because they might not be able to get it back. Suspending their Medigap when they become newly eligible for Medicaid is a nice way for them to be able to retain their eligibility to get that plan back and also um, save some money. And with that, I will stop for questions. Did anyone have questions about that information?
There are questions in here, Katie, so let's go ahead and we'll take a few before we before we hop on to the next section. Let's see here. What does partial dual eligibility mean? Could you explain that?
Sure. So sometimes we talk about full benefit dual eligibles and partial benefit dual eligibles, or full duals and partial duals. Full duals are people who have full Medicaid coverage in addition to Medicare. A partial dual is someone who just gets limited Medicaid, for example, through the Medicare Savings Program. We're going to talk about the Medicare Savings Program later, but primarily people who get help through the Medicare Savings Program get help where the state pays their Medicare Part B premium. So those folks are called partial duals.
We have a question about Medigaps. So is it okay to wait to choose a Medigap policy if they're still employed with health benefits?
So if you are waiting to enroll in Medicare Part B because you are still employed and you have health benefits through active employment through your employer, you don't need to enroll in a Medigap yet. You would wait until you enroll in Medicare Part B, and then you get that 6-month Medigap open enrollment period. So that Medigap open enrollment period is tied to when you enroll in Medicare Part B.
I have a question here about somebody who wants to decline Part B. So the question is, if somebody declined Part B coverage due to what they call comparable coverage, but didn't enroll back into Medicare once that coverage ended, so that comparable coverage ended, when would be their time to enroll in Part B? Would it be during the open enrollment period, October through December, or would it be that general enrollment period, January through March?
Yeah, if this person is not eligible for a special enrollment period, that would allow them to enroll now. They would need to wait for the general enrollment period to enroll in Part B.
Let's see here. Let's take one more if that's okay. And I know there's a lot in here, but due to time, we'll take one more here. And the question is, when somebody who had Medicaid, when they first became eligible for Part B, um, basically, I'm going to say the question is, would they have a special enrollment period or a guaranteed issue, I should say, to enroll in a Medigap policy if their Medicaid benefits ended?
Sadly, no. No, that's something that we would really like to see if people want to contact their legislators about that. During the public health emergency, after the public health emergency ended, there was a period where people losing Medicaid had a guaranteed issue opportunity to enroll in a Medigap. That has ended. So there is not a general guaranteed issue right to enroll in a Medigap if you lose your Medicaid, sadly.
All right. And if we do have time at the end, I'm sure we can go back to a lot of these questions, but we're going to go ahead and move forward.
Yeah,
And we're
thank
going
you.
to, yes, thank you, Katie. I think that was a lot of great information. And I hope for those of you who are learning about Medicare, I hope that helped you lay that foundation for what we're going to talk about moving forward. And that's going into our Medicare updates for 2025. It's hard to believe it's only a little more than a month away, right? So I'm going to start off with some just very general updates, and then we're going to move into some more significant updates with Medicare in 2025. So the first two updates are here on this slide. The first one relates to dental coverage, and what you had learned with what Katie had talked about is Medicare itself, original Medicare, doesn't typically cover dental services, things like routine dental or comprehensive dental. It was really only in super limited circumstances. Medicare Advantage plans may have some dental coverage for individuals. It could be routine or comprehensive coverage as some extra benefits they add into their package. But there was some um, movement on dental coverage with original Medicare Parts A and B. And in 2023 and 2024, the physician fee schedule codified some payment rules associated with dental services under Parts A and B for very specific circumstances relating to medical procedures. So those circumstances relating to medical procedures revolve around people who are having heart valve repairs or heart valve replacements, organ transplants, or cancer related treatments where they need to have something done dental wise for those particular treatments to be effective, safe, or actually to have some of those specific treatments. So, for example, with heart valve repair or replacement, could be routine dental exams or treatments needed before those replacements or repairs occur. Or if somebody had a tumor in their mouth, that could be something like a dental ridge reconstruction at the same time they're doing that cancerous tumor removal. So it's very specific. And if you have any additional questions about that, we can send more of that guidance. The other general update for actually just came out recently is that CMS announced that PrEP, and I'm going to have to make sure I say it correctly here, it's a mouthful, pre-exposure prophylaxis retroviral drugs, those that prevent HIV, are now a preventive service because they are preventing HIV. So what does that mean for people who are using PrEP? Well, instead of being covered under Medicare Part D, as in drugs, they will now be covered under Medicare Part B, as in boy. There was a national coverage determination that you can feel free to click on the link when you have the slides that was recently published that goes into more detail about this. But for Medicare beneficiaries, I think the important thing to know moving forward, now that it's a preventive service, is their pharmacy that they're receiving this drug from has to be able to bill Medicare Part B as in boy. So they would want to talk to their pharmacist, make sure they're able to do that billing with Medicare Part B. And on the good side of it as well, it means that since this is a preventive service, there should be no cost to the beneficiary for the PrEP medications. So that's a good update. So we're going to move into some more things that I know people were anxious to hear about, to learn about. And first up is our Medicare costs for 2025. We were anxiously awaiting these costs to be released. Every day we were looking, and they were finally released on Friday, and it seemed like it was late Friday afternoon. So we do have the cost for 2025. And just as we anticipated, Medicare costs have consistently, gone up each year, and they went up this year for 2025 just a little bit. So we're going to start off with Part A. And Medicare Part A, um, for most people, does not have a monthly premium. If you've worked enough quarters, you don't pay for Part A, or you can collect off of a spouse who's worked enough quarters. But if somebody has not worked enough quarters, you can see that there is a premium for Medicare Part A, and it depends on how many quarters you've worked. So you can see 30 to 40 quarters, it's gone up to $285 a month, and if you've worked less than 30 quarters, it's $518 a month. But again, the vast majority of people do not pay for Part A. Now, in addition to the Part A premium information, we also have the information on the Part A hospital costs. So with Part A, there is a Part A deductible per benefit period, and that went up to $1,676 per benefit period. The cost for a hospital stay, if you are in the hospital, for days 61 through 90, so you've been in there a while, have gone up to $419 a day. And the same with days 91 through 150, they've gone up to $838 a day. Skilled nursing, that has also gone up just slightly to $209.50. They added that 50 cents on there. Now, I think a lot of people tend to be more focused on Medicare Part B and the monthly premium that typically comes out of their Social Security check, or if they're not receiving a Social Security check, it's what they get billed for uh, quarterly. And the standard Part B premium for 2025 has gone up just about $10 to $185 a month, and that's the standard premium. Again, we'll learn a little bit later that if you have a lower income and resources, you may not have to pay that Part B premium. And people who have higher incomes would pay a higher cost per month for Medicare Part B, and that's kind of on a sliding scale. Um, and if you have or want information on that, we can provide that to you. It's called IRMA. The Part B yearly deductible has also gone up to $257 per year. So, like I said, the costs have gone up, but they've gone up what we anticipated they would have gone up to. Now, Medicare Part C or Medicare Advantage, which Katie had talked about in the previous slides, those premiums, deductibles, co-insurance, and cost-sharing amounts, they all vary by plan. So we're in that time of year where people need to take a look at their plans to see what's out there and available to them if they want to be in a Medicare Advantage plan or already in a Medicare Advantage plan to make sure those premiums, deductibles, and their cost sharing amounts still fit their budget and their needs. Now, if somebody has a Medicare Advantage plan, it's still important for them to remember they would have to pay a Part A premium if they had one, but they still have to pay that Part B premium. So again, most people, again, do tend to pay a Part B premium. So with the Medicare Advantage plan, on top of the premium you would pay for that plan, you would have to pay that Part B premium. Now, Medicare Advantage plans, as I stated, their premiums vary. We have plans that are $0 a month. Actually, a lot of plans that are $0 a month across Pennsylvania. The plans that are well over $200 a month. So again, prices vary. The same with Medicare Part D. The premiums, the deductibles, and the cost sharing for individuals would depend on the plan that they are in if they're choosing a standalone Part D plan. So again, right now is the time to shop around for 2025. So let's take a look at what Medicare Part D looks like in 2025. And it's important to talk about this and what Part D is going to look like in 2025 because there were changes to Part D that are going to start in 2025. Now, I just mentioned that Part D plans vary by their premium, their deductibles, and cost sharing amounts. But Medicare itself lays out the framework for Medicare Part D. So they post the guidelines um, in what is called the standard drug benefit, and that's what's on your screen. Part D plans themselves can choose to be a standard Part D plan and really look like what is listed on the screen, or they can choose to be a little more enhanced. Maybe they have a different premium, lower premium, higher premium, lower deductible or no deductible, and then they can choose to offset their cost sharing in different ways, which we'll discuss. But for 2025, the standard Part D benefit um, starts off with that premium. And again, premiums vary by the plan, but we have two numbers on your screen. One is the national base beneficiary premium. The other is called the regional benchmark premium. And you're like, what does that mean? What do those numbers mean to me? So the first number, that national base beneficiary premium, is really the average cost of a Part D plan for a Medicare beneficiary in the United States. And that's $36.78. You say, that's great, but what does that mean to me? Well, if somebody has a Medicare Part D penalty, that penalty amount is based off of that number. So if that base beneficiary premium fluctuates, goes up or down, their Part D penalty would go up and down based off of that number. The second number, the regional benchmark premium, you can see that's a little bit higher, $48.36. So here in Pennsylvania, we're lumped in with West Virginia in a CMS region. So we are, I think we're in Region 6, if I remember correctly. In that region, our benchmark premium is this $48.36. So if somebody has, and we'll talk about it here shortly, extra help, and they want to choose a plan that is a benchmark plan or a standalone Part D plan where they may not have or they would not have a premium, that's where this benchmark number comes into play. So we have and I'll talk about those plans. We have a few plans available in Pennsylvania that are roughly $48.36 a month. So if somebody has full extra help, they can enroll in one of those Part D plans and not have to pay a premium. If somebody's interested in a Medicare Advantage plan, the same applies. They could enroll in a Medicare Advantage plan, and if it did have a premium, their premium may be reduced by that roughly $48 per month. The best way to find out what cost would be to use the Medicare Plan Finder, which we'll again discuss a little bit later on, and how to use that, what you can find out with the plan finder and how that can help individuals navigate this time of year. So on top of that premium, in the standard Part D drug benefit, there is a deductible, and it's gone up to $590 for 2025. Now, here's where we see the first big difference from previous years with Medicare Part D. So we're going to move from a deductible phase into the initial coverage phase. That is the same. And for most people in a standard plan, they're going to pay 25% of their drug cost during this initial coverage phase. And that could be by paying 25% exactly or through a copay system and tiered drug levels. But here's our difference now. In 2025, there is going to be an out-of-pocket cap on how much a Medicare beneficiary can pay for their formulary Part D drugs for a calendar year. And that number in 2025 is going to be $2,000. And we'll talk about that in more detail on our next slide. But what happens then when somebody meets that $2,000 cap in 2025 is they move directly into the catastrophic coverage phase. If you've been on these webinars before or have learned about Medicare Part D, you might remember there was a point in time where there was a coverage gap or a donut hole, and it was technically went away. a few years ago, but now that coverage gap is completely gone off of our screen, and somebody would move directly into catastrophic coverage, paying nothing for their formulary Part D prescription drugs after they've met that $2,000 cap. And that would be for the rest of the calendar year. And you keep hearing me say formulary Part D drugs, and I'm going to keep reiterating that because it's important to remember that a drug has to be on their Part D plan's formulary to be covered, and this cap only applies to Part D drugs, not Part B drugs. So let's talk about that out-of-pocket limit just a little bit more. It was part of the Inflation Reduction Act, and it was a provision or a way to simplify the structure of Medicare Part D. And Medicare Part D has been around since 2006. And with its inception, it was confusing on how it worked. And over time, things changed a little bit with Part D and the structure of Part D. But now this implementation of this cap has really simplified Part D to where you have a premium, a deductible, initial coverage phase, straight to catastrophic coverage. Now, that $2,000 cap that I had mentioned on the out-of-pocket cost for prescription drugs with Part D is subject to change annually. So it's $2,000 in 2025, but it could go up in subsequent years. Again, it's on the screen. The drug must be on the plan's formulary to count towards that out-of-pocket cap. And again, it's the time for people to shop around right now. So it behooves them to do that to make sure their drugs are on the formulary. And again, there's no cost for covered Part D drugs after the individual meets that $2,000 cap, and that is for the rest of the calendar year. So that's really exciting news, particularly for people who have very expensive Part D medications. So building upon that, something else new for 2025, and that is the Medicare Prescription Payment Plan. The acronym for that is MPPP. And again, that's a mouthful to say. So the best way to describe the Medicare Prescription Payment Plan is it is a way that a beneficiary can spread their Part D drug cost out throughout the calendar year. It's kind of like budgeting it out. Now, all Medicare drug plans, and that is Part D plans, Medicare Advantage plans, are going to offer this option to pay for out-of-pocket Medicare Part D cost in these monthly payments instead of going to the pharmacy and having to pay your copay or coinsurance amount at the pharmacy counter. And this starts right at the beginning of the year. Participation in the MPPP payment plan product is completely voluntary. A Medicare beneficiary can choose to enroll if they want to. Again, if they choose to enroll in this payment plan option, they will pay nothing at the pharmacy counter. Instead, their Part D plan is going to bill them each month for any cost sharing that was accrued, again, while they were enrolled in that payment plan option. Looking at this, and I'm going to show you a calculator tool in a few slides, the Medicare beneficiaries more likely to benefit from this payment plan option are people who have really high drug costs early in the calendar year. People who have very low drug costs, people who have sporadic drug costs or costs that can fluctuate throughout the year probably are not going to benefit from this. And people who have extra help, um, people who are enrolled in PaceNet, people who are receiving any type of assistance with their drug costs are really not going to benefit from this program. Again, it's people who have high drug costs at the beginning of the year that may choose to enroll in this because they could see a benefit in that payment plan option. But again, they may not. That's why it is completely voluntary. So let's just quickly look at the logistics of how this would work for a Medicare beneficiary. So if somebody is interested in enrolling in this payment plan option, you can't call Medicare and do it. You cannot call PA Medi and say, help me enroll in this. They have to go directly to their plan. So their Part D plan is who is going to enroll them into this payment plan option. If at any time during the year they decide, well, I'm going to switch from XYZ plan to another plan because of a special enrollment or during, Medicare Advantage open enrollment or whatever the case may be. If they're enrolled in this payment plan option with one plan, it does not roll over to the next plan. If they wanted to be in it with the next plan, they would have to contact that plan to continue that option. And with this Medicare plan, payment plan option, Medicare beneficiaries cannot be dropped or what we'll say disenrolled from their Medicare Part D plan for non-payment of their Medicare prescription payment plan drug bills. So they're going to get these monthly bills for their drug costs. If they don't pay those, they can't be disenrolled from their Part D plan, but what can happen is they can be terminated from the prescription payment plan and basically reverted back to the traditional way of paying, your drug costs at the formulary, or excuse me, at the pharmacy, and then the plan itself would work with the beneficiary to again try to recoup any of those back payments that they owed. Oops, sorry. Here is a quick look at that calculator I was mentioning. So Medicare.gov and the Medicare Plan Finder on Medicare.gov, and I apologize because it's tiny on the screen, but they do have a calculator available to Medicare beneficiaries who are using the tool online. So if they plug in their drug costs, and they either do that within a Medicare account or they could just do it generally, there is a link where they can click the link and the link will show them their cost with or without that payment plan calculator applied. So when I quickly did this, I put in an expensive drug for somebody that takes it, throughout the year. And you can see that if they were in the payment plan option, it would really just level those costs out and they would pay the same amount for the rest of the year. Whereas if they were without the payment option, they would pay a few really high months of cost sharing and then they would pay nothing for the rest of the year. So it's very much a personal preference. And I would encourage people who think that they are interested in this to use this calculator before making any decisions. So just a few takeaways from this because it is new for 2025. This Medicare prescription payment plan option is just a way for somebody to spread those drug costs out throughout the year. It does not lower their costs in any way, and it does not help them save money. It's just a budgeting tool for those individuals. Medicare beneficiaries have to continue to pay their plan premium, so their Part D plan premium or Medicare Advantage plan premium, whichever they are in addition to paying those monthly bills that are sent out by their plan. And I think that's something to be aware of because now the person would be receiving two bills, which could be confusing. Again, participation is completely voluntary for a Medicare beneficiary. And if somebody, again, is interested in this payment plan option, it it really would be a good idea for them to take a look at assistance programs like Extra Help, the Medicare Savings Programs, and PACE and PACENet here in Pennsylvania to see if that could be an option for them because those programs really do help lower out-of-pocket costs. They lower drug costs and help somebody save money. Now, there are a few tools when you have your slides you can click on, a video about it from CMS, and a quick fact sheet for you to take a look at. So let's hop into just a few more slides before I turn it back over or take some questions and then turn it back over to Katie. But we're going to talk about the plan options here in Pennsylvania in 2025. So we're going to start with Part D standalone. So that's just a Part D plan by itself. We've dropped in the number of standalone Part D plans here in Pennsylvania for 2025. There's going to be 14 of those available. And out of those 14, only 2 of them are considered to be zero premium plans for people who have full extra help. So, are people who are dual eligibles, people who are in the Medicare Savings Program, people with just full extra help, those individuals who are receiving extra help, those individuals have 2 options available to them that would cost them nothing. There is a list. Again, the list only has 2 options on it, but you can click on that link to take a look at those 2 options. It's Silver, Script Choice, and WellCare Classic. On the Medicare Advantage plan side, I'm going to say that's wildly different now. So the number of plans has, of course, increased. And you saw Katy's slide about the number of people enrolling in Medicare Advantage plans has gone up. Well, the number of plans has gone up. So the average amount or average number of Medicare Advantage plans in most counties is around 65 plans. And those are just typically HMOs and PPO plans. One county has, let's see, 85 Medicare Advantage plans on the high end. On the low end, we have a county that has 39. But everybody's kind of right there in the middle around that 65 number. On top of those, I call them standard type of Medicare Advantage plans. There are also the special needs plans out there and available to individuals who are or meet certain conditions. So Katy had mentioned our dual eligible individuals may be eligible for what are called D-SNP plans or dual eligible special needs plans. That's the most common type of special needs plan available in Pennsylvania. Every county has them. Some counties have quite a few of them, upwards of 19, and some counties on the low end have maybe about 8. The other types of special needs plans that are out there are I-SNPs, I as in the letter I, which stands for institutional. So that's for individuals who may be in a nursing facility. And then we also have C-SNPs, which are for people who have chronic conditions. And they're very specific in the chronic conditions that they're devoted to. And again, not all counties have I-SNPs or C-SNPs. So that's a lot of acronyms thrown in there for sure. Now, focusing in quickly on those zero premium Part D plans that I had mentioned, and the number of Part D plans that it's kind of shrunk for us here in Pennsylvania. I wanted to just talk about that because there were 2 plans in 2024 that were offered. One was AARP Medicare RX Basic, and the other was Cigna Secure RX. Those 2 companies are no longer offering the zero premium plan options for people who have extra help in 2025. So those individuals who have extra help and are currently enrolled in one of those 2 plans should have received a notice in the mail, a letter, one of 2 notices. One would have been on blue paper. It's called a reassignment notice, and that is if the individual was auto-enrolled in one of those 2 plans by CMS. The notice would be saying that they would be reassigned to one of the other standalone zero premium Part D plans for 2025, unless they chose something else on their own. And then the other letter that would or could have gone out to individuals is on tan color paper. It's called a chooser's notice. And what that means is an individual selected on their own either the AARP plan or the Cigna plan. And the letter's basically letting them know that if you don't do anything, you are going to have a premium now for this plan in 2025 because it's no longer considered one of those benchmark zero premium plans. And as a side note, this was on our slides last year as well. A little bit about Clear Spring, because I know some people may say, well, that's still listed potentially as a zero premium Part D plan for those who have extra help. Well, Clear Springs is still under sanctions, and it could potentially be terminated at the end of next year. If somebody is currently enrolled in Clear Spring, they can stay in Clear Spring, no problems there. But Clear Spring cannot market, nor can they enroll people in their plan for 2025. So it doesn't show up on Medicare's plan finder. So we excluded that from our list because you can't technically enroll in it right now. I wanted to add this particular slide in here because we're just doing some updates on the plans available in Pennsylvania. And I wanted to bring this 5-star plan update into the mix because um, back when we were talking about special enrollment periods at the beginning on Medicare Basics, we had mentioned that there's a 5-star special enrollment option on that chart for individuals who might want to enroll in a 5-star plan. I'm bringing this up though because this year in 2025, there are a lot fewer 5-star plans available across Pennsylvania. So that's really going to limit that special enrollment period option to people who live in certain counties that do have a 5-star plan available. And really, there's only one company that has 5-star plans in 2025, and they only operate, and they're only on the Medicare Advantage plan side. And again, they are not in all of the counties in Pennsylvania. So again, that option may be significant for a few people who wanted to use that option as a way to switch plans. All right, I think that's my last slide there. So we'll see if, did we have any questions
We
while I take a
did.
drink of water?
Yeah, we did have some questions. Thank you, Jess. All right, one person asked if a patient has a non-formulary request through their Part D plan, does the cost still cap at $2,000, assuming their non-formulary request is approved?
If it's, excuse me, if it's approved, I'm going to say it will be put on their formulary for them, and then it would be considered a Part D drug because it went through that coverage determination process.
Okay. And then there was a question about whether chemotherapy gets paid through Part D. And I see that in the chat, some folks answered that it depends.
Hmm.
Some IV chemotherapy is paid through Part B,
Hmm.
and some specialty chemo is only through Part D. It depends on whether you're getting it in a hospital or clinic setting or if you're self-administering it.
Correct.
Okay.
And there's a
Just
really nice, if anybody ever wanted it, a Part D versus Part B chart from Medicare that kind of explains a lot of those types of things.
all right. There was also a question about the MPPP, and do people have to enroll in that during open enrollment?
So they do not have to enroll during open enrollment. They can enroll in MPPP, right? That's hard to say, right? Anytime they want to during the year, but the key to that is if somebody's enrolling close to the end of the year, they're probably not going to see any value in that at all. But yes, they can enroll whenever they want to with the plan, and there are certain guidance and guidelines on how quickly the plan has to respond to the person so that they don't have to pay for those medicines at the point of sale at the pharmacy instead of, of course, being enrolled in that payment plan option and getting the bill down the road at the end of the month.
Okay. And then there was a question, you had mentioned that there are various types of special needs plans, D-SNPs, I-SNPs, C-SNPs. Is there a list of chronic conditions that have C-SNPs?
That's a great question. So there's a tool available. It's called the CMS Landscape of Plans. That's probably the quickest way to find out if there is one in your county, and it can be sorted. It's an Excel spreadsheet. But the other way that somebody can find out if there's C-SNPs is using Medicare.gov, and you can put in your zip code of where you live and choose to look at Medicare Advantage plans. And there are filters on there that you would be able to check if there was a C-SNP available to see those plan options. And then the plans themselves should list in their information what the specific type of condition would be. I know arthritis is one that I've seen often, or COPD. But honestly, in Pennsylvania, I feel like those C-SNPs aren't as prevalent. They're in more populous counties than some of our other areas of the state where um, we've never had them before.
All right. Oh, there are so many questions. I think we may want to stop here. I'm sorry
Mhm.
to everyone who is putting questions in the chat and the question and answer. Just so that we get through the materials, I think we're going to take a break here, but we will try to come back and get some of these.
Yes. Would you like to do a poll, or do you think we should just move on to
Yeah,
time?
go ahead and launch another poll.
Okay, let's see here. Let me pull up a poll for you guys. Let me go back here. We're going to do this one. I'm going to ask where you guys live and where do you work? So go ahead and answer that for us right now. That's
And
an
what?
easy one, huh? Break
Yeah.
it up.
Yeah, break it up. And while you're answering, I just wanted to say thank you for being such an engaged audience. It's sometimes weird doing webinars because we can't see you all, but it really helps to know that, as you're asking questions, it's really helpful to us, and we really appreciate your engagement.
Well, let's see here. I just ended that poll. So it looks like the majority is in the southeastern part of the state, just followed up by the southwest, which I kind of figured are more populous areas. So thank you for answering those questions. We'll do the last one. How about that? We'll just throw it in here, Katie, if that's okay.
Sure.
One more poll question for you guys.
Now that we know where you are in the state.
Right, right. Let me see if I have to go back and I have to stop sharing this one. All right. Which best describes you? Are you a Medicare beneficiary? Are you a caregiver? Do you work with older adults? Do you help people with disabilities, or both? All right. I'm going to end that poll here. Let's share the results. All right, so it looks like a lot of you work with older adults and those with disabilities. That's the vast majority again.
Okay.
So thank you guys again for answering those. It was very, very helpful, and I hope it broke up a lot of this difficult information. And I'm going to turn it over to Katie, who's going to share some more complicated information, right?
Thank you, Jess. All right, so one of the big changes for 2025 that impacts low-income Medicare beneficiaries is a change to the Part C and D special enrollment period for dual eligibles and people with extra help. So just to, again, for making sure we're all on the same page, currently there is a special enrollment period for people who are dual eligible for Medicare and Medicaid, and those who have extra help with their prescription drug costs, that they can change their health or drug plan once per quarter during the first 3 quarters of the calendar year. The current special enrollment period allows people to switch between Medicare Advantage, Original Medicare, and a Part D plan. Changes made during the first 3 quarters of the year start the first of the next month. And then right now, after September 30th, duals and people with extra help can use the annual open enrollment period if they want to make changes for January 1st. So this special enrollment period is changing for 2025, and an additional special enrollment period has been added for full dual eligibles. So let's get into that. We wanted to spend some time on these changes because I think this is going to be confusing for a while. So that quarterly special enrollment period for duals and those with extra help that I just went over is changing in 2025 to a once per month special enrollment period for enrollment into a standalone Part D plan. So starting on January 1st, the monthly dual eligible extra help special enrollment period will allow a once per month election to leave a Medicare Advantage plan for original Medicare in a Part D plan or to switch between standalone Part D plans. So what that means is people will no longer be permitted to use this special enrollment period to switch their Medicare Advantage plan or to enroll into a Medicare Advantage plan. So previously, or in 2024, people could use that special enrollment period to switch Medicare Advantage plans. That's no longer going to be an option using this special enrollment period. So that is a big change. There is also a new integrated care special enrollment period. This one is for people who are full benefit dual eligibles, will be able to enroll monthly into certain dual special needs plans that provide integrated and aligned enrollment with their Medicaid managed care organization. And there are only certain D-SNP plans that meet the criteria for this special enrollment period. So let's just go over some definitions quickly. We did this a little earlier, but just as a reminder, full benefit dual eligible is someone who has Medicare and full Medicaid coverage. So those are the folks who will be able to use this new integrated care special enrollment period. Partial duals are people with Medicare and limited Medicaid through the Medicare Savings Program. Extra help, also called the Low Income Subsidy or LIS program. LIS only people are people with Medicare and extra help only and no Medicaid. So what this new integrated care special enrollment period does, it allows full duals to switch from original Medicare and a prescription drug plan or another Medicare Advantage plan to an eligible D-SNP that's aligned with their Medicaid managed care plan. So what this means is that to take advantage of this integrated care special enrollment period, the person must be enrolled in a Medicaid managed care plan that has an aligned D-SNP. So really what this means is that the only duals in Pennsylvania who will be able to take advantage of this new special enrollment period are people who are in the Community Health Choices plans. So in Pennsylvania, most dual eligibles are enrolled in Community Health Choices plans for their Medicaid coverage, but not everyone who has, not all duals are in a CHC plan. People who are in the intellectual disability system or who are enrolled in an autism waiver or an intellectual disability waiver through the Office of Developmental Programs, they are not enrolled in Community Health Choices plans for their Medicaid, so they would not be eligible to use this new special enrollment period. So these are the current integrated care special enrollment plan options for 2025. You can see the current CHC managed care plans and the aligned dual special needs plan that qualifies for this special enrollment period, or for the special enrollment period. If additional CHC plans are added, there may be more companion D-SNP options, and we would encourage you to see our newsletter for updates about this. The Department of Human Services had announced back in August that some additional CHC plans were selected through a request for applications process to administer Pennsylvania's Community Health Choices program. But there have been challenges to the plans that were selected. So right now everything is in a stay. So these are the CHC plans that are in place right now. These are the CHC plans that will be in place until that challenge process has ended and the competitive procurement process has ended. So just kind of stay tuned for that. But for now, these are the plans, and people enrolled in these plans will be eligible to take advantage of this new integrated care special enrollment period in 2025. So we just kind of wanted to put all of this on one slide in case it's helpful. As kind of takeaways about these changes to these special enrollment periods for 2025. I know the dual special enrollment period is something we talk to people about all the time because we talk to so many people who are dual eligible or lower income Medicare beneficiaries who have extra help. Um, so, we also wanted to make sure we understand this. So for full benefit dual eligibles, they'll have that monthly special enrollment period that they can drop their Medicare Advantage plan and switch to original Medicare with a prescription drug plan. They also could use that monthly special enrollment period to switch their prescription drug plan. They have a monthly special enrollment period to switch from Medicare Advantage or Original Medicare to an aligned D-SNP, and that is only if applicable. So like we talked about, that only works for duals who are enrolled in a CHC managed care plan, but they no longer have that quarterly special enrollment period to change Medicare Advantage plans other than to an aligned D-SNP. So you may need to look for, if you're working with a Medicare beneficiary, a dual eligible, they may need to look for other special enrollment periods. We talked earlier, there's lots of other special enrollment periods, but this is one that we know that duals and people with extra help really took advantage of previously. Partial duals and people with extra help only, so people who just have help with their Medicare Part B premium or just get help through the extra help program with their prescription drug costs, will have that monthly special enrollment period to drop Medicare Advantage and switch to original Medicare and a prescription drug plan, or to switch their prescription drug plan, but that's it. They no longer have a quarterly special enrollment period to change their Medicare Advantage plan. So I think this will take some getting used to. So we wanted to just quickly walk through some examples to kind of help this sink in. Lisa is a full benefit dual eligible. She is currently enrolled in Geisinger Gold's D-SNP Medicare Advantage plan for her Medicare and has UPMC's Community Health Choices plan for her Medicaid. In May, Lisa found out that her current primary care physician is no longer going to be in network with Geisinger, and she doesn't want to change providers. So what are her special enrollment plan period options? So as a full benefit dual eligible, she could disenroll from Geisinger's D-SNP and return to original Medicare and a Part D plan using the monthly SEP for duals and people with extra help. So that would leave her with original Medicare, a Part D plan, and then the UPMC CHC plan for her Medicaid. She could also use that new integrated care SEP to switch from her Geisinger D-SNP to the UPMC D-SNP that aligns with her Medicaid managed care plan. If neither of those things is a good option for her, you could see if she meets the requirements for another special enrollment period with less restrictive rules. Because it's May, we know she's already missed the Medicare Advantage open enrollment period, which would have allowed her to just switch to a different Medicare Advantage plan, whatever Medicare Advantage plan she wanted. I think these changes to the special enrollment period demonstrates that the Medicare Advantage open enrollment period might become more important for people. Hopefully people will see within the first 3 months of the year whether the plan that they're in is working for them, so they can take advantage of that period if they're enrolled in a Medicare Advantage plan and need to switch. And then if Lisa wasn't enrolled in CHC for her Medicaid, she wouldn't be able to use that integrated care SEP. All right, so now example two, Jane, 63, is enrolled in a Medicare savings program. So she is a partial dual. She currently has original Medicare with a Part D plan and wants to enroll in a Medicare Advantage plan so she can get those extra dental and vision benefits that original Medicare doesn't cover. She is outside of the annual open enrollment period. So does Jane have any special enrollment period options that could help her? So that monthly special enrollment period for duals and people with extra help would allow her to switch to another Part D plan, but that doesn't help her because she's trying to get into a Medicare Advantage plan with extra vision or dental benefits. So then you have to check and see, does she meet the requirements for any other special enrollment periods that might have less restrictive rules? Jess mentioned the 5-star plan. If she were to enroll into, there's a once a year special enrollment period to enroll into a 5-star plan. Um, is Jane eligible for Medicaid? Is there another assistance program that she could maybe enroll in? If she's eligible for the MAUD program, Medical Assistance for Workers with Disabilities. If someone becomes eligible for Medicaid, that gives them a special enrollment period to change their health or drug plan. Otherwise, Jane's going to have to wait for the Medicare annual open enrollment period to change plans for the following year. Okay, last example, Tim is 68. He has original Medicare and a Part D plan with extra help. In April, Tim had an ER visit and found out he has a heart condition and now needs to see several specialists on top of his PCP. So he's now having a hard time affording his original Medicare cost sharing for his provider visits and subsequent tests. So Tim wants to enroll in a Medicare Advantage plan to help him budget his costs. Is there an option for Tim to do that? So like Jane, Tim could use that monthly special enrollment period for people with extra help to switch to another Part D plan, but that's not going to help him with his original Medicare cost sharing. So then you need to check and see, does Tim meet the requirements for another special enrollment period? For example, Tim is over 65. Could he enroll in PACE or PACENet to help him with his prescription drug costs? That would give him access to a once a year special enrollment period to change his health or drug plan. Again, the 5-star plan. And then check to see if Tim qualifies for another assistance program. Is he eligible for the Medicare Savings Program? That would give him access to another special enrollment period. Otherwise, he's going to have to wait for the annual open enrollment period to change plans for the following year. He could try applying for a Medigap, but we don't know if he'll be accepted or if that would be affordable to him. But that is another option. Okay. So I know those changes are a little confusing.
I, I was going to say, I know there are a few questions in here, and I know we have about half an hour left, but I think this one question is really important to bring up right now because you and I had actually talked about it as well. But somebody did ask if a dual wanted to switch to a D-SNP plan that's not aligned with their CHC plan, can they first change their CHC plan?
Yes, they could.
Mhm.
So, with Medicaid, you can change your plan every month, your Medicaid plan every month. Um, you know, the problem with that idea, so yes, that is an option. It's going to take time though. If I wanted to change my Medicaid plan, um, I have to do it by the second Thursday of the month for it to switch for December 1st. So if I switched my Medicaid plan today, that would take effect December 1st. And then once I was in December, then I could change to use that new integrated care special enrollment period to change to the aligned D-SNP for January 1st. So you can see, let's pretend it's 2025. Then those dates make sense. But that's going to be a 2-month process. And then the question is, how is that going to impact the person's care? You have to make sure that the providers are still in network. There can be authorization issues. So that is an option. The concern is that it could impact people's care if they're, kind of constantly switching plans to try to get into a different Medicare plan.
All right, I'll leave it at that right now due to time here. And I'm going to finish up with the 2025 updates before we move into the programs that help with Medicare costs. So these are just some brief slides, just as reminders for anybody out there who, again, works with our older adults or people with disabilities who are on Medicare. So an important thing to remember is, well, reminders about marketing and communications. I know that there are a lot of commercials on TV and people get a lot of messaging and mail. I know I've heard of multiple people tell me they have stacks of mail about Medicare products on their dining room table. They can't even use the table because it's covered. So I think it's important to talk about what is allowed and what is not allowed. So there are some unsolicited marketing activities that are allowed that are pretty common. Things like conventional mail. So again, flyers, letters, postcards, all of that that comes in the mail is allowed. Other print media is allowed as well. So advertisements in newspapers I know are very popular. All of that can happen through a third party marketing organization or through the Medicare plan itself. They're also allowed to email Medicare beneficiaries information as long as there's an opt out option. So, somebody, I know most people might just delete it, but there has to be an opt out option in that email from the plan or third party marketing organization. Now, on the flip side of that, there are a lot of prohibited activities that are considered unsolicited marketing or communications activities. And I think a lot of them are pretty common, pretty self-explanatory. But no door-to-door solicitation is allowed. That would even include something like an agent or a broker coming up and sticking flyers about their products in your door, but no door-to-door solicitation. No solicitation in common areas of a healthcare setting, so like the lobby or the emergency room waiting area, that is not allowed. No direct social media contact, so that would be like direct messaging somebody on Instagram or through Facebook Messenger, that is not allowed. Cold calls directly to Medicare beneficiaries that are completely unsolicited. That is not allowed. And I know we do still hear about a lot of those cold calls happening. And marketing of non-health related products when somebody is meeting with an agent or a broker. So that would be going in and talking about Medicare Advantage plans, but then somebody tries to sell you an annuity or a life insurance product while you're there for the meeting about the Medicare Advantage plan. Those things are prohibited. There's also some good guidance on marketing and communications, reminders about things like rewards and incentives and gifts that companies or plans may be giving out. So, on the rewards and incentive side of things, they are allowed to give out rewards and incentives, but those must not be used in exchange for enrollment into the product. So, they can't give me a t shirt in exchange for me into enrolling into a particular plan. Um, if there are rewards and incentives available, they must be provided to all potential enrollees without discrimination. And specifically, Medicare Part D plans, so those standalone Part D plans, cannot develop or use marketing, rewards, or incentive programs. On the gift side, again, gifts can be provided, but they have to be for marketing purposes to potential enrollees and very inexpensive, so $15 or less. And if somebody's receiving multiple gifts during the year, in total, they cannot um, be $75 or more. It has to be $75 or less in those nominal gifts. And of course, it can't be contingent on them enrolling into a particular plan, and it cannot be in the form of cash or monetary rebates. So, those are just some quick reminders. And if somebody does feel that they are a victim of marketing violations or enrollment fraud, there are resources out there and available. PA Medi, again, the State Health Insurance Assistance Program here in Pennsylvania, can help an individual if they feel like they've been a victim of either of those um, marketing violations or the enrollment fraud. The Senior Medicare Patrol, which is a sister agency to PA Medi, they really delve into marketing violations and fraud and abuse with Medicare. Again, any type of anything that seems off or unscrupulous, or where somebody does feel like they were violated, can be reported to the Senior Medicare Patrol, which is operated by Carey out of Philadelphia here in Pennsylvania. And of course, we have 1-800-Medicare. Any of this can be reported to 1-800-Medicare, and they would take the claim and put it into the system for verification. And what 1-800-Medicare can also do for somebody who feels like they've been a victim of these marketing violations or enrollment fraud is they can request to have a special enrollment period put in place for them if they were, again, a victim of marketing violations or enrollment fraud. They can call Medicare to request that, or you can also work with your local PA Medi office to request that special enrollment period due to marketing violations and enrollment fraud. Moving on to just a few more of our quick updates, because I know people have been asking about this. And when is it going into effect? All kinds of questions. But it's Future Inflation Reduction Act changes. And the big one that still is on everybody's mind is the negotiation of drug costs that Medicare had discussed and put forth a few years ago, where they are allowed to work with the drug manufacturers to, again, negotiate prices for certain high cost drugs. Now, last year, they had put out the list of the first 10 drugs that were going to be negotiated, and those negotiated prices would go into effect in 2026. So we still have to wait a year. And then subsequently, from 2026 on through 2029, additional drugs would be added to that negotiated um, drug list. So you can see the first 10 drugs on your screen, and there is a link if you wanted to see what those negotiated prices look like for 2026. And just to throw it out there again as a reminder of the tools available to our Medicare beneficiaries, the Medicare Plan Finder on Medicare.gov is a fantastic tool where an individual can take a look at the plans available in their zip code area. They can look at Part D plans and Medicare Advantage plans. They can sort through those plans, can even enroll in plans through the Plan Finder. The best way to do it is to create a personalized account. You don't need an email address to do that. You would need your Medicare card to do that, though. When you do create a personalized account, you can save your drug list, your preferred pharmacies. You can update that information. You can also utilize that payment plan calculator if that was of interest to you. You can see changes to your current plan that you are enrolled in. What's that going to look like for me for next year? And you could also, again, as I mentioned, enroll in a new plan for 2025. But once you enroll in a plan through the Plan Finder for 2025, that information is then posted in your account. So you get a confirmation number, and you could see that processing, and then it will show up as your plan for 2025. So it's a great idea for people to set up that account, because you can really navigate through a lot of information in a one location.
All right.
All
Why don't
right.
we keep going
Yes.
just because of time? And Jess, I don't know about your schedule, but I can stay
Hmm.
on at the end to
Yes,
answer
that's fine.
questions.
Sure.
Um, Okay, so let's get into programs that help with Medicare costs. And I know someone asked in the chat, do we get a break? I'm sorry, we had so much information to share. Feel free to take a break and jump back in. As Dana mentioned at the beginning, we will be sending out the materials and the recording afterwards. So if you need a break, take one. We're going to keep going, but you'll have the materials afterward. Okay, so we know we've talked a lot about Medicare is expensive, and we know lots of people have trouble affording their Medicare costs. So we're going to go through a few programs that can help with those costs. If you can go to the next slide. Okay. So this is just a graphic showing that poverty is pervasive in Medicare. Lots of people really struggle to afford their Medicare costs. These are the programs we're going to talk about. There are links to, we have fact sheets about the Medicare Savings Program on our website, fact sheet about the Extra Help Program. Feel free to click on those links, download those resources. They're really helpful to share with clients or for your own use. I'm going to talk first about the Medicare Savings Program. This is also called the Medicare Buy-in Program. That's what the County Assistance Office calls it. So the Medicare Savings Programs are a Medicaid program that helps with people's Medicare Part B premium primarily. The state pays your Part B premium. That is the primary benefit that most people enrolled in the Medicare Savings Program receive. People with very low incomes, under 100% of the federal poverty level, also get help with their Medicare Part A and B deductibles and cost sharing, and any Medicare Part A premium they may have. You don't have to already be enrolled in Part B to get the buy-in, but you do have to be eligible for it. One of the great benefits about the Medicare Savings Program is if you are eligible for the Medicare Savings Program and have a late enrollment penalty, the Medicare Savings Program can help you get enrolled in Part B if you're not already enrolled at any time of the year. So you don't have to wait for one of those enrollment periods we talked about. And it eliminates any late enrollment penalty that you have. So if you have a late enrollment penalty, enrolling in the Medicare Savings Program, if you're eligible, will wipe that out. Even if later you're no longer eligible for the Medicare Savings Program, that late enrollment penalty is eliminated. Not everyone with Medicaid is eligible for the Medicare Savings Program. It is its own category of Medicaid with its own income and resource limits. So people have to qualify in particular for this program. I did include a link to the Medical Assistance Eligibility Handbook, which includes all the rules for how the Medicare Savings Programs work. I'm going to skip ahead. This is who qualifies for the Medicare Savings Program. I think I saw a question in the chat about the income and resource limits. We don't know those yet for 2025. This slide has the income and resource limits for 2024. Income limits for these programs come out usually around February. So, stay tuned. We'll put out updated fact sheets. We'll include information in our newsletter when those income and resource limits change. But to qualify, you have to have Medicare Part B or be eligible for it and meet these income and resource limits. Not all income and resources count. This is a Medicaid program. These programs follow the SSI counting rules, if you're familiar with those income counting rules. So only if you have earned income, only about half of your earned income counts toward these limits. The first $20 is disregarded of any unearned income. So if someone seems to be close to the limit, it's worth reviewing to see if they could qualify. And then most people, as I said, just get help with their Medicare Part B premium. Just talked about how it's going to be $185 a month next year. So that's a big benefit. And then people in the lowest income category also get that other help with their Part A and B cost sharing. You don't have to apply for a specific Medicare savings program. That gets worked out on the back end by the County Assistance Office. MSP can be authorized up to 3 months retroactively in certain circumstances. So sometimes people can ask to be eligible for 3 months back and get a couple months of the Part B premiums they've paid back reimbursed. If people want to, you can switch to the next slide. If people want to apply for the Medicare Savings Program, there is a particular application for that the PA 600M form. It's a shorter application specifically for the Medicare Savings Program, or you can apply on Compass. That's just a much longer application that also reviews your eligibility for other programs. That's not a bad thing but if you know you just want to apply for the Medicare Savings Program, that 600M form is a little shorter. You do have to submit verification documents with your application to the county assistance office, and you should receive a decision within 30 to 45 days in writing, and that decision is appealable if you are denied. There was a question in the chat about someone who didn't have Medicare Part A. The most people get the buy-in for Medicare Part B. There is also a Medicare Part A buy-in program for people with very low incomes. Usually we see this for people on SSI who do not have enough quarters of coverage to get Medicare Part A for free. As Jess mentioned, most people get Part A for free, but if you don't have enough quarters of coverage or you don't through your spouse, then you would have to pay a pretty high monthly premium. We know there have been problems with people getting into the Part A buy-in program. If you are working with someone or you are someone on SSI, in that Healthy Horizons Medicaid category, and you are not enrolled in the Part A buy-in, reach out to the county assistance office and ask to be reviewed for it. We included a link to a policy clarification that DHS put out a couple years ago to clarify to the county assistance offices that they are supposed to be enrolling people in the Part A buy-in. There's been a lot of systemic changes with the Department of Human Services systems to try to improve access to the Part A buy-in, but we still hear from people who are having trouble. Once someone is enrolled in the Part A buy-in, they should get a new red, white, and blue Medicare card that shows that they have both Part A and Part B. Feel free to reach out to us if you are having issues with that, though. That is something that we can help with. And I'm going to skip this example so that you can talk about extra help, Jess.
Sounds good. We're going to wrap it up here with the rest of the assistance programs. And I'm going to talk about Extra Help, which is also known as the Low Income Subsidy Program. This is a Medicare benefit, and everybody who has extra help now has full extra help. That was a change that went into effect in 2024. The program itself helps lower premiums for Part D plans, either again, standalone Part D plans or with a Medicare Advantage plan. So it lowers premiums, deductibles, co-pays or co-insurance amounts. If somebody has a Part D penalty and they qualify, it's wiped away. And it does allow enrollment into a Part D plan if somebody is not already enrolled into a Part D plan. Now, being that this is a Medicare benefit, it is administered by Social Security and CMS. And just briefly on this slide, this extra help is extremely important because Medicare Part D can be expensive between premiums, deductibles, and cost sharing amounts. This extra help program was created back when the Part D program went into in existence in 2006, really to help people with limited income and resources afford their Medicare Part D cost. And there are so many people new to Medicare every day that don't know about this program that it's really important to get the word out. So if they are eligible, they can potentially enroll. So what does it mean if somebody has extra help? Well, I said it lowers their drug cost. So you can see here on the screen what it looks like for somebody who has extra help in 2025. So they would get a premium subsidy up to that regional benchmark amount of a little over $48. And, and they have no deductible on top of that. And depending on what category they fit into, their copays could be different. So if somebody is receiving Medicaid long-term care, so they're on the waiver or they are in a nursing facility, they don't pay anything for their formulary prescription drugs. If somebody is receiving full Medicaid benefits, their costs are going to be $1.60 or $4.80 for those formulary Part D drugs. And if somebody is receiving just the Medicare Savings Program or just extra help, then their costs are a little higher at $490 and $1215. And those do go up year to year. So who qualifies for the extra help program? Well, if somebody is already receiving any type of Medicaid benefits, they get full Medicaid benefits or they're getting their Part B paid for through the Medicare Savings Program, they don't need to do anything. They will automatically get extra help. No application required. Anybody else who's not receiving Medicaid benefits who feels like they may qualify for the program would need to apply, and Social Security processes the applications. Of course, they're going to have to meet income and resource guidelines for this program, which again, we have the 2024 numbers right now. You can see them on the screen. Very similar to what Katie said, not all income and resources count towards the limits. So I always say, when in doubt, fill it out. The worst they can say is no, that you are not eligible for the program. But again, these numbers will increase next year. And once we get them, they will be updated. So again, if they're receiving medical assistance or any sort of Medicaid benefit, no application is required. If somebody needs to apply, how do they do that? Well, the quickest way is to go online to Social Security's website and apply. It's pretty easy to find on there. You can see the link. You can click on the link to go to the application. You can also call and you can do the application on the phone with Social Security, or you can request a paper application. Some people automatically get a paper application in the mail that's kind of pre-filled out as well. They can fill that out and send it in. No photocopies of a paper application are accepted because it's on very specific scannable paper. So let's talk about dual eligibles and extra help. So again, they are automatically going to get the extra help benefit. So these are people who have both full Medicaid and Medicare benefits. They don't need to do anything else. Their extra help is good for at least the calendar year. But if something happens, and if they're on Medicaid between July and December, they're good for the entire following calendar year as well. And if they lost Medicaid benefits during that time, they would keep their extra help pretty much till the following year. And we're going to explain that in a slide coming up here. I think it's important for people to know their extra help status. So again, if they have a Medicare account, they can check that information, or they can call Medicare at 1-800-Medicare to find out their extra help status. So speaking of people losing extra help, and we'd mentioned mailings just a little bit earlier. So more Medicare beneficiaries are going to be losing their extra help benefits at the end of this year due to the pandemic health emergency unwinding. And it's really those individuals who were terminated from Medicaid in July of 2023 through June of 2024. Because they don't have Medicaid benefits, they are no longer automatically eligible for extra help. And they will be notified, and they should have been notified already by now, um, on a gray piece of paper, a gray letter that states this information. And there are actually approximately 69,000 people in Pennsylvania that should have received this gray letter. Inside the gray letter envelope, there's also an application for extra help. They can fill out that extra help application, send it back in to be processed and looked at again for eligibility for the program in 2025. If they don't do anything and they've received this gray letter, they don't do anything, don't fill out an application, their extra help benefit would end at the end of this year. Of course, they can complete a new application at any time if they just didn't know what they needed to do. On top of that, we may have people who get an orange letter that talks about the changes in extra help copay levels because people may have moved from one category of Medicaid to another or move from having Medicaid benefits to just having extra help benefits, potentially their cost could change. So that orange letter would show them what their cost would be in 2025. And finally, there's one other blue letter that may have gone out to people back in the August, September timeframe. It's a redetermination letter from Social Security. Basically, randomly selects people for an eligibility review. They would get the notice. It's on, again, a pre-filled type of application. And if they completed it and sent it in and they were still eligible, that's fine. They're going to move forward with extra help. But for a lot of people, they may not know what that is and they don't send it in. And if they don't send it in, they would be terminated from those extra help benefits. Of course, they can reapply at any time. And if you wanted to see more about the Medicare mailings, there is a link on the slide. So let's say we have 69,000 people who have received that letter that say they are no longer automatically eligible for extra help. What else is out there for them if they really don't qualify for extra help? Well, we have PACE and PACENet here in Pennsylvania. Um, it's the state's pharmaceutical assistance program. It is specifically for people age 65 and older and Pennsylvania resident of 90 days, at least 90 days, and they must meet certain income guidelines. There's no resource test to PACE or PACENet. You cannot have full Medicaid benefits and be eligible for PACE or PACENet, but you can have Part D or a Medicare Advantage plan and enroll in PACE or PACENet. PACE is the lower of the two income guideline programs. PACENet is a little bit more moderate in their income guidelines. PACE looks at the previous year's income. So we're in 2024 right now. They would be looking at 2023 currently. And they do not count the amount that you pay for your Medicare Part B premium in that income calculation. So that's really nice as well. If somebody qualifies for PACE or PACENet, what it would do for them, primarily, the number one thing people apply for PACE and PACENet for is to lower their drug costs. So your copays would be capped on the PACE program at $6 or $9 for a 30-day prescription. And with PACENet, it would be $8 or $15 for that 30-day prescription. People can apply for PACE online. They can call. There are paper applications as well. But if you go online or you call, they will process that application very quickly. In like 5 or so business days, you would be notified if you are eligible for the program. And you can start using it right away as well. Again, with PACE or PACENet, it can be somebody's only drug coverage or only source of drug coverage. It is considered creditable drug coverage for Medicare Part D purposes. But most people tend to have PACE or PACENet along with a Part D plan or a Medicare Advantage plan with drug coverage. Now, if somebody doesn't qualify for PACE or they're not old enough for the program, there is something else out there that doesn't hurt to look at. It's called the PA Patient Assistance Program Clearinghouse or the PA PAP. We tend to call it the Clearinghouse here in PA, but it's a program sponsored by PACE, and somebody can call into the clearinghouse or click on the link to apply. And what they will do is help navigate programs that are available, like manufacturer programs, to see if there are any programs available to assist with somebody's drug cost. This is available to anybody age 18 and up here in Pennsylvania. So it's a really great resource that I think a lot of people don't know about. And last but not least, we don't want to forget about Medicaid. People, of course, can apply for Medicaid benefits, and it can be the person's only insurance, or if they have Medicare, it can be their secondary coverage to help pay that Medicare cost sharing. Here in Pennsylvania, our Medicaid program is run through the Department of Human Services, and eligibility determinations are made through the local county assistance offices. If people have questions about Medicaid more specifically, we can get into that into the chat, but I know we're running right up to the end here. I want to make sure that you get your resources in. few resources out there. We spoke about PA Medi quite a few times, and I know we have a lot of PA Medi counselors on today. PA Medi is the state health insurance assistance program here in Pennsylvania. The number on the screen is their um, toll-free helpline that you can call into. There's also a link to the Department of Aging where you can find local events or local contact information for PA Medi. But PA Medi counselors are unbiased. They are trained to help people explore their Medicare options, choices, talk about what is available in their particular counties. They can help people apply for extra help, the Medicare savings programs, and PACE and PACE Net, and they can help enroll or change Medicare plans. So give them a call if you need assistance. We also have 1-800-Medicare that we mentioned. They are open 24/7, so you can call them any time of the day. They can answer your questions about Medicare. They can also help look at Advantage plans and Part D plans, and they can check things like your extra help status for you. And then, of course, as we talked about at the beginning, we are here with the Pennsylvania Health Law Project. We can help with problems getting Medicaid coverage, Medicaid services, eligibility, or service denials, and we can provide advice about Medicaid eligibility, understanding coverages, and troubleshooting other things that may be out there, like inappropriate medical bills. So please feel free to follow us on social media. You can see we have all of the social media pages that you can follow us on. You can sign up for our newsletters and get lots of great updates. And I really recommend visiting the resource library. There's a lot of self-help information and guidance out there on that resource library, plus other webinars that have been recorded for you to view. So I know that pushed us right up to 12, right on the dot. So again, I'm here to stay if people have questions. I know, Katie, you said you were as well.
Yeah.
So feel free to drop off if you need to, but we can answer some questions.
Yeah, thank you so much for joining us. And the last slide of our materials has my contact information,
Yes,
Jessica's contact
that would help.
information. Our helpline is here, so feel free to reach out to the Health Law Project or to us if you have follow-up questions. I was able to answer the questions in the question and answer box. I responded to them. So if there are other questions in the chat, let's just see if we missed anything.
I did see one about somebody asking if they didn't receive one of the blue letters,
Mhm.
what they can do. Unfortunately, I'm sorry if you didn't receive the blue letter and you should have, but I would recommend either going on to Medicare.gov and taking a look if you have an account to see what plan you currently have and what that would look like for you next year. And if you did want to switch plans, of course, you can do that through Medicare.gov's website or contact PA Medi and they can help you as well navigate that information on Medicare.gov if it is a little confusing.
Yeah, and we'll be sending out the recording and slides along with the post-webinar survey to everyone who signed up for this presentation. So don't worry.
Yes, it's a lot of information.
It is a lot of information. Yeah. Oh, thank you. Thank you for all the kind comments. Yeah, and apologies if we missed anybody's question. Feel free to reach out.
Yes.
Thank you.
Right.
Thank you all.
Thanks so much, Jessica and Katie. Are you planning to stay on or are you done with the questions for now? Just so I'm clear.
I think we are
We
good
got them
to
all?
close.
Okay.
Yeah.
Okay, that's great. Well, thanks for,
Uh,
thank you both for sharing your knowledge. I'm always impressed when I listen to both of you, even though we talk all day at work. It's so fascinating to hear how much knowledge you both have about this system. So like, yes, as Katie and Jessica said, we're gonna circulate the materials, and any questions, just feel free to reach out to us. And thanks for joining. Have a great day, everyone.
Thank you.
Bye.